Now coming on to the management of a case of a iatrogenic colonoscopic perforation. In 45 to 60% of the cases, the perforation is detected by the endoscopist during the procedure itself. However, in the rest of the cases, the perforation is detected usually after the procedure on the basis of the clinical signs and symptoms. And in these cases, the perforations can ultimately lead to the development of full-fledged perforation peritonitis, which increases the morbidity and the mortality of the procedure. Data has shown that the mean delay in the diagnosis of perforation was about 8 hours after a diagnostic procedure and about almost 1.5 days after a therapeutic procedures. And depending upon the delay in the diagnosis and the start of the management and presence of any pre-existing pathology, iatrogenic colonoscopic perforations have been shown to have a mortality of anywhere between 5 to 25%. After a colonoscopy, any patient who complains of abdominal pain and has abdominal tenderness or distension, starts running a fever, or has an episode of rectal bleed should be suspected as a case of iatrogenic colonoscopic perforation. This should be immediately confirmed by getting an X-ray of the abdomen done, which can show either free intra or extraperitoneal air. Now, data has shown that a plain X-ray of the abdomen and thorax has a positive predictive value of 45% and 100% for diagnosing perforations because of therapeutic or diagnostic procedures, respectively. If a plain X-ray does not confirm or rules out a perforation, one should immediately request a contrast-enhanced CT scan. And this is very reliable and can easily detect even small amounts of free air and fluid. So if a patient has only localized peritoneal signs, a double contrast CT can not only diagnose the perforation but can also help us to decide the suitability of going in for a conservative management. Now, on a CT scan, when a perforation happens in the intraperitoneal parts of the colon, which means the cecum transverse or the sigmoid colon, you will see a free intraperitoneal air. Whereas a perforation of the ascending and the descending colon and the rectum usually leads to free extraperitoneal air, which can be seen either in the retroperitoneum, mediastinum, or even present as subcutaneous emphysema. Do remember that gas in the right anterior pararenal space is seen in a case of ascending colon perforation, and that in the left pararenal space is usually due to a descending or a rectal perforation. And rectal perforations actually generally cause bilateral pneumoretroperitoneum also. Coming on to the management. Now, three alternative forms of managements are available. You can treat the patient either conservatively or via endoscopic therapies or surgically. Once an iatrogenic colonoscopic perforation is confirmed, the decision between surgical and non-surgical treatments will depend upon the time period which has elapsed between the diagnosis and the start of the treatment. This is the most important factor as far as the prognosis of this patient is concerned. Besides this, you must also look at the characteristics of the perforation vis-a-vis what is the size of the perforation, what is the location, what is the underlying pathology and the etiology of this perforation. Also consider the quality of the bowel preparation and whether the patient is hemodynamically stable or not. The expertise which is available to treat this complication is also going to factor in while deciding the management. So talking about conservative management of colonoscopic perforations, this is usually suitable for small sealed off perforations in patients having a good bowel preparation. So any patient who presents with localized pain and has been confirmed as a case of perforation but is still hemodynamically stable and is not having sepsis can be managed conservatively. Conservative management, as we all understand, basically involves absolute bowel rest, good hydration, starting a broad spectrum antibiotics, and serial repeated monitoring of the patients so as you can promptly detect any signs of sepsis or peritonitis. It is a good idea to drain the massive intraperitoneal air which is present in cases of perforations. Now, conservative management is associated with low morbidity and mortality and a short hospital stay in appropriately selected patients. And the overall success rate with this conservative management varies anywhere between 30 to 90%. Now, endoscopic treatment of a colonoscopic perforation. Endoscopic closure of a perforation is possible when the perforation is recognized either intra-procedurally or within 4 hours of procedure and the bowel preparation is still good. Now, there are different methods of endoscopic closure, and the choice depends upon the size and the cause of the perforation, what is the endoscopist's experience, and whether the appropriate endoscopic devices are available or not. Now, endoscopic treatment basically includes closing of that defect, which can be done either using endoclips or with the suturing devices. Now, endoclips are non-operative methods of closure for the perforation, which are recognized during colonoscopy. You basically have two kinds of clips. Either you can deploy them through the scope, or what we call as the TTSCs, or you have the over the scope clips, or what we refer to them as OTSCs. The two commonest kind of OTSC clips are Ovesco and the padlock clips. Both are equally effective for early closure of defects and can avoid surgery in most cases. Clips have an overall technical and a clinical success rate of 93 and 89% respectively. The through the scope clips are limited by the small opening width and the closure strength of the jaws, and hence they are more suitable for closure of smaller perforations, usually less than a centimeter in size. However, they cannot adequately close large defects and full thickness perforations. So this is an image which shows a perforation which has happened in the cecum during a polypectomy, and the adjoining image shows that that perforation has been completely closed by the application of 3 TTSC clips. A special mention about perforations happening during a ESG procedure. So after the completion of dissection, one must always look for and rule out a target sign, which basically appears as a white gray circular disc at the center of the area of transection. Now, this represents injury to the colon's muscularis propria layer and is highly predictive of perforation. So, this should immediately prompt for an endoscopic closure of the defect using TTSC scopes. As you can see in the adjoining image, a target sign is beautifully seen in the image on the right side, which has finally been prophylactically closed using 6 TTSC clips. Again, an image showing a large post EMR defect in the cecum, which was completely prophylactically closed using TTSC clips. Now, as far as the OTSC clips are concerned, they offer a strength comparable to surgical suturing. And because of their bigger size, they can allow closure of larger perforations up to 2 centimeters. These clips are made of a special nitinol alloy, which is a combination of a nickel and titanium, and this makes this nitinol biocompatible and MRI conditional. So OTSC clips closures have a technical success rate of almost 80 to 100% and a clinical success rate of anywhere between 60 to 100%. Now in this image, you can see that a OTSC clip is being used for a large perforation closures. To approximate the edges of the perforation, we use this twin grasper, which can individually catch hold of the two edges of the defect, bring them in close opposition before you can deploy a OTSC clip and close the defect. Besides the clips, an alternative method of closing these perforation is by endoscopic suturing. So this Apollo overstitch device is one of the commonest ones which is being used, and contrary to only mucosal approximation which is achieved with endoscopic clips, the endoscopic suturing actually creates a full thickness surgical quality sutures through the colonic wall, creating a very reliable and airtight closure. You can see here, these are the images showing a colonic perforation which has happened during a ESG procedure and which was managed entirely endoscopically by the means of endoscopic suturing. However, there are certain limitations of this endoscopic treatment of colonoscopic perforations. The first being that it is difficult to evaluate the completeness of the colonic closure after clipping, and this may sometimes result in a delayed complication such as a leak or an abscess. And secondly, Perforations in the right colon, especially in the cecum, can usually be repaired only using the TTSCs because of the inability to reach the site of the perforation with an endoscopic suturing device or OTSC clips, especially if the colon is tortuous or unclean. Coming on to the surgical management of these perforations. Now, surgical treatment is recommended in patients with signs and symptoms of peritonitis, those who have a large perforation, patients who have a concomitant colonic disease which would in any case require a surgery, patients who have had a transplant, immunosuppressed patients, and patients in which there is a failure of the conservative management or failure of endoscopic closures also. So please remember that early success with non-surgical treatment does not rule out the potential need for a surgery. The best surgical technique should be decided after a thorough inspection of the abdominal cavity and considering the underlying colonic pathology. So you may either go ahead and do a primary repair if the colonic tissue is healthy and well vascularized and the approximation of the perforation edges will not cause any tension, or you may select to do a wedge resection, or sometimes you may go ahead with a complete colonic resection at the site of perforation, especially if the perforation is found to be too large or the edges are devitalized, or if on examination you see that there is an avulsion of the adjacent mesentery of the colon. However, it is better to go in for a colostomy and a staged repair in cases of delayed presentation or when there is extensive peritoneal contamination and the patient is hemodynamically unstable. So I would end my talk by giving this simple message that the future is hybrid for all of us, and as surgeons we should all strive to be a surgeon as well as an endoscopist. Thank you for your patient hearing.